Yeah, yeah.
There are plenty of seats up front. You're welcome. Yep. Thank you everyone for coming tonight for the CSUCI HeaLS panel presentation on telemedicine, provider and payer perspectives. My name is Blair Barker and I am a lecturer here in the Health Science Department. Dr. Clovis regretfully cannot attend tonight due to a family emergency, but we are blessed with this lovely panel that's going to present. Please don't forget to sign in. We have the QR code that you can use. This is how any of your professors who might be offering extra credit will be able to know that you attended. There will also be a random drawing for 2 prizes at the end of the presentation tonight. You do have to be present in order to get the prize. But why don't we go ahead and get started. Dr. Cabaret and Dr. Kwong, this question goes for both of you. Can you please give us an overview of how you use telemedicine in your practice?
Okay. I'm a psychologist practicing in Ventura. So prior to pandemic, I wasn't really using any telehealth in my practice. It's just all in-person sessions, but during the pandemic everything shut down and we went to telehealth sessions very quickly, like within a week or 2. So during the lockdown, and that's all we did exclusively, just through video, phone calls, and that's all we did. Now things are opening up, so I would say maybe roughly 50-50. I'm still doing telehealth about 50%, and there's some patients I have never actually met in person. They still prefer just doing video sessions, and there's some that requesting to come in and have been coming in. So that's what I have been doing.
Thank you. Dr. Cabaret?
Hi, I'm an anesthesiologist, pain management specialist, and addiction specialist. And same thing, when the pandemic hit, we were doing no telehealth before. We immediately went to almost all telehealth and did that for quite a while. And then as soon as things started opening up, we went back to sort of a mix. Right now, I'd say maybe 5% of my practice is telehealth. I'm really trying to discourage people from using that, but it helps when someone's sick or they're out of town or something comes up. It's a really nice tool to have.
Thank you. Lisa Green, this question goes to you. Please explain to us what your role is at your organization and how it relates to telemedicine.
Sure. So hi everybody, Lisa Green. I work for Optum, which is a very large organization, but the division within Optum that I work for is the care delivery. So we own and operate all of the primary and specialty care medical practices across Southern California. So the team that I lead is called Digital Transformation, and we sit basically between IT and the end users of technology and try to help facilitate, implementing new digital tools and technologies and IT platforms. So we kind of act as a buffer between like the physicians or the staff that might have to use, say, a telehealth platform, and the IT team who, typically speaks a little bit more IT. We're kind of like that liaison or that translator to just help ensure that, the users are getting what they need and that we're developing and rolling out tools that meet the user's needs. So when you think about a primary care or a specialty practice, Same thing as these two clinicians here. You know, at Optum, we had done a little bit of telehealth, but when COVID hit, that's when things really got busy. We probably ended up, for a while, everything was shut down. But at that time, we didn't have a consistent telehealth product or platform that we were using across the Southern California market. So my team had to step in and just really quickly identify what telehealth product we were going to use. So because we had to do it quickly, we oftentimes have to make like a build or buy decision. So do we want to develop something ourselves, or do we just want to go out to the marketplace and buy something that already exists? And so obviously in this case, we had to act quickly. And so we decided to contract with a vendor and use a telehealth platform that had already been in use. So my team helped get the market ready. We helped, train everybody on the new platform, let them know how to use it, help kind of talk through what appropriate telehealth visits would be versus, when it might not be appropriate. And we were all just trying to figure it out at that time. But here we are, 3.5 years later, and we're not doing telehealth as much, but it definitely is something that our patients expect, and we do want to meet our patients where they're at. So I would say we do about 17% of our visits still are telehealth, but patients do like to come in and see their doctors face-to-face as well. So it's a supplement to the regular day-to-day care.
That's wonderful. And so this next question, Lisa, kind of goes a little bit more off of what you were just saying.
Mm-hmm.
What are some of the elements of your organization's telehealth tools that the providers have found to be the most helpful?
Yeah. With the platform we use, one thing they really like is the way that you initiate the visit with the patient. So when the provider's ready to see the patient, all they have to do is initiate the visit by sending the patient a text or an email. Most patients are doing the visits on their phone. So they'll just get that text, and it's a really quick connect, and it's really easy and usually makes that visit start and go really quickly. So that's been really nice. A couple of other interesting features are that say the physician joins the visit first and the patient's not there for some reason, there's like a nudge function where you can send another text to the patient to be like, hey, I'm waiting for you. So that helps because clinicians' time is very valuable and they don't like sitting around waiting for their patients. So that's been a really nice feature too. And then there's another good one where if a physician's meeting with a patient and maybe it's an elderly patient and they need like help from one of their children or something like that, they can add that like third person into, so it's just like a group chat, they can add that third person into the video visit directly from the telehealth platform. And that gets used a lot for, like I said, like children or maybe spouses or significant others. They can also bring in translators. So if maybe the doctor speaks a little bit of Spanish, but the patient speaks more, they can bring in a translating service to really help facilitate that visit. So I'd say those are probably the top 3 areas that our physicians really like in our telehealth platform.
That's wonderful. Thank you. Dr. Cabaret and Dr. Kwong, what has been the greatest benefit of using telehealth to your practice and to your patients?
Want to go first?
Sure. I think there are quite a few benefits, and one of them is good access. People can really kind of get into telehealth sessions easier. They don't have to drive to my office, especially for some people who may have transportation problem. I do see children, so sometimes, it gets complicated if a parent who has a child being sick at home, and so you can't take another child could come into my office. We could just set up the video and then we could just talk at their own home. So the cancellations and no-show rate actually has dropped quite significantly because of that. The other thing is that for me, the benefits would be too that like I can kind of observe, like if they're doing it in their own home, I could kind of observe where they live, like if they're family setting. So, sometimes when I see the children, they will say, oh, do you want me to show you my room? I said, sure. They show me the whole house. So I got to see where they live, do they have their own room? or maybe when they're talking to me, I could hear some people yelling outside, so I get to assess the family situation that they may not be able to tell me if they come into my office. They also feel very comfortable sometimes because, they're at their own home. They may say, oh, let me get a cup of tea before I talk to you. So they're already in a more relaxing state. So that could be one of the benefits for me to they already feel like they feel comfortable, they can talk more, they can open up more. And as for me, as a therapist, I also have more flexibility. I can work from home. During the pandemic, I basically just worked from my own home office. I may not need to go to the office on a Friday. Or if they miss an appointment, I could easily say, okay, I'll just see you later on this evening. I don't have to wait for them at my office if they have to reschedule. So there's a lot of benefits for me as well. For the patient and for myself, we could travel. If they have to visit a family member for holidays, then I could still see them, so they don't have to miss the sessions as much. And for me as well, if I travel, I could also see them. Now, however, there are some guidelines because I am licensed in California. So basically, I can see anyone when I go to another state. But for the patient, they have to be resident in California. So if they travel or they move to, let's say, Hawaii, then I no longer can see them because my license is only allow me to see people in California. So that could be one of the restrictions.
Thank you, Dr. Kwan. Dr. Cabaret?
Yeah, for me, it's just a convenience factor. I think for me, I'm the patient. When someone is sick or for whatever reason can't come to the office, it allows us to provide care and for them to get care, in that setting. But really, for us, an office visit is ideal.
Yeah. And that brings me to my next question, Dr. Cabaret and Dr. Kwan. Can you please describe 2 or 3 challenges, or the greatest challenges that you've experienced using telehealth?
So for me, the challenge has been, there's a couple challenges. I'm in a field where I need to do a physical exam, and I can do some of that on Zoom. So I can watch people bend over and do other things, ranges of motion, things like that, but I can't really get my hands on them to test for certain things that require an in-person exam. So that's challenging. Another challenge is, you can't really have that same bond that you have with a patient in person, where you're making eye contact. If I'm looking at you and you're looking at me, we can kind of read each other's body language and, develop a rapport that on Zoom isn't possible, because if I'm looking at the camera, I can't see your eyes. And if I'm looking in your eyes, you're not seeing my eyes. And so it really does create, I think, a big disconnect. I found it very challenging to have more sensitive conversations, delicate conversations. I do a lot of motivational interviewing in my practice, which really is something that requires it requires more of a in-person. I think it's easier. You can build trust better that way and talk about, like I said, sensitive topics. People can see you. They know that you're not. I think it's harder to read what people are all about online.
Thank you.
Yeah, or on the phone.
Thank you. Dr. Kwan?
Yeah, I totally agree on that point. I think that as for me, it is difficult to see the body language because when I see someone in session, it's important to sort of know how they're feeling, including reading the body language. So in the camera, you only see really, mostly half of the body or from your chest up. So someone could be, tapping your feet because of your anxiety or playing with certain objects with your hands, which I would not be able to see. But if someone comes into my office, I definitely can observe that behavior, and that's part of my assessment. I think that another challenge is that, part of the assessment, if someone comes in a crisis, someone could be having some psychotic symptoms or being suicidal, it's really hard to assess what's going on without being face to face. And, like for instance, if someone is suicidal, it depends how much of a risk they are. So I may have to kind of make some phone calls while the person is in my office. But if someone is at home, I may not be able to get a hold of anybody, or the person may not want to give me the phone number or how to contact anybody. So that definitely can be a challenge. I also see some older adults, so technology can be a challenge, right? So in the beginning, it's like, how do I do this video camera? And sometimes they just ended up just wanting to talk on the phone. But and sometimes they don't know how to use the technology, or some families may not have a smartphone, so you're not even able to do a video chat. And I know sometimes in the beginning, they don't even realize how to use the camera, so they have to realize that I can see exactly what they're doing and they can see what I'm doing. But in the beginning, they may not know, right? So for instance, in the beginning, I remember I saw this older woman, and she was sitting in her room, and then she started going to another room, and I said, "Where are you going?" And she said, "I'm going to the bathroom."
Oh, no.
So I said, "Okay, I think you need to somehow put the phone away and go in and then come back." So, things like that she wasn't even thinking. So that could be a challenge. But the other thing is it's really about the connection. So when someone is in distress, they may be crying, they may be having a very difficult time, and it's really hard to connect with them. And the physical presence really plays a big role in kind of how to help someone feel more comfortable, make them feel like they're being supported. So with the screen, it's really hard just to say that you have some connection. If a patient is wanting at the end of a session, after a very stressful, very difficult session, that person may ask for some physical contact, like, I would like a hug, as a sense of comfort and support, but that's not going to be done in video. So a lot of times what I do is I actually verbalize that challenge. I would just say, this is really hard for you, and I wish that, we would be there in the same room, having some sort of connection, but we can't. So when I verbalize that, at least I could address the issue rather than just sort of not thinking that this is a challenge at all. So same thing with the body language. Like I can see, what's going on. But so what I do is I compensate by asking more questions. Like for instance, I see someone, I don't really know how tall they might be, and sometimes I may not even know how much, they weigh. So certain issues may come up, like for instance, if I've seen someone who said, "I lost a lot of weight," and I would ask like, "Oh, typically how much do you weigh? And how much do you weigh now," right? Because I can't really tell by just looking at the camera. Or so someone may say, "Well, I am 5'5" and I'm only 95 pounds. Like, okay, that's a serious problem, possibly. So to sort of deal with that challenge, I just end up asking more questions.
Thank you. The next thing we want to ask both Dr. Cabaret and Dr. Huang is, what changes would you like to see with telehealth technology?
That's I don't know.
Okay, that's
I mean, I don't know how we could improve it. It's a screen and it's a camera. If we could get our eyes closer to if I could get my camera closer to the person's image so that it looks more, or at least it feels and looks more like eye contact, and have that on both ends, I think that would improve the experience. You know, we all know that when you're on Zoom, everybody's kind of looking down like this and they're talking, but if we could put that picture of the other person right up under the camera, we could see them and they could see us better.
I think maybe some of the technology needs to be improved. Maybe it depends on the platform. So I use this platform called DasiMe. The connection is not always good. Like sometimes it sort of freezes, and sometimes I would see the patient already waiting for me, but they can't see me. So a lot of time I have to say, hello, hello. If they don't wave back, that means they can't see me. So, and I have heard other platforms also have issues. I don't know, Lisa, you have that experience. But so I think that, you know, that would help if there's more improvement. Sometimes then we really just lose a connection. So in the middle of the session, we got interrupted. So I think that in terms of technology, that could improve as well.
Thank you. Lisa, can you share some examples of features that providers have asked for that your team was unable to provide? And why could they not be incorporated into the technology?
I would say the biggest thing we haven't been able to do is the providers want they want a seamless workflow. So most providers spend their day in an EMR or an EHR. When they're getting ready to see the patient, they look up the chart, you know, get the history, see why the patient's being seen that day. And so in our situation right now, they have to go to they have to open a web browser, log into the telehealth system, and then have the telehealth visit there. And then, like you're saying, Dr. Cabaret, they have to look back at the chart, look at the telehealth thing. So it's not seamless at all. So what they really want is for the visit and the telehealth platform to be embedded within the EMR. It does exist today. There's you know, like Epic is a very popular EMR that does have that capability embedded within it, but we don't have that today. And so having kind of just that fragmented workflow has been a challenge, and it's not something that we've been able to make happen for them. So I would say that's the biggest thing. And honestly, a lot of it too is just if their support staff can better set the expectations with the patients. It doesn't really have to do with the platform, but like the connectivity issues you were mentioning, like sometimes patients will be like at the grocery store and they'll try to take their video visit from the grocery store, and it's bad Wi-Fi or it's no Wi-Fi, and they're in a public place and it's loud, and so, you know, our clinicians have asked us like, hey, can you please like set the right expectations for the patient, be home, make sure you're on Wi-Fi, not cellular, like these will all make the visit go better, things like that. So yeah, those are the most common.
Okay, thank you. Can you share, Lisa, what parts of Optum use telehealth the most?
Yeah. For us, it's definitely heavily skewed toward primary care. So, you know, again, when we started doing this after COVID and we've kind of revamped our program, the most appropriate visit types for us are like if a patient maybe has an upper, like basic colds and flus, maybe GI issues, so they're having diarrhea or stomach problems. You know, they can't really do physicals via telehealth, so that's probably the biggest thing that primary care clinicians can't do. We do have some specialists that do video visits as well in telehealth, but they're definitely more rare. Dermatology is trying to get into it because now with the video, they can at least try to see like the rash or whatever's happening with the patient's skin. But I'd say 9 times out of 10, they want the patient to come in anyways because, like you said, you need to be able to see them, touch them. If it's a mole, you don't want to, you know, misdiagnose or miss something. So definitely skews heavier on the primary care side. We also have a couple teams that use telehealth that are kind of unique. So we have a health education department. So like if a patient is newly diagnosed with like diabetes, for example, we can send them to our health education department, and that team educates them on, okay, this is how you can change your diet, and this is, you know, maybe some medication you might need, and these are some lifestyle changes you can do. So that's been really helpful because there's maybe one health educator, but they're able to actually do an education class with like 30 to 40 people in it. And so we can really touch a lot of patients that way, and really make a bigger impact. And the last team that's kind of unique that uses it, we have a pharmacy support team. So if a patient is prescribed to a new medication and maybe it's complicated, or you know, they have to take it like twice a day, or they have to go into a clinic to get an infusion, you know, if it's just something that's new to them, we have a pharmacy support team that actually does a video visit with the patient, walks them through what this, you know, cycle of this medication is going to look like for them. They even can like put up all their, this is with our elderly patients too, and people with a lot of chronic conditions, like they can set up all their pills on a table, and like the pharmacist will walk through everything just to make sure everything's, you know, yes, they're taking the right things, nothing is, you know, counterintuitive or not supposed to be taken together, and then they can check the patient's medical record to make sure that what the patient's taking is what the doctor prescribed. So having that as kind of a unique support team as well has been really great.
That's great. Thank
Yeah.
you. Thank you. Are there any parts that really don't use telehealth, and can you maybe discuss a little bit of why?
Yeah, I definitely think this like for, again, like physicals and things where the patient just needs to be there in person, that's really hard because you do need to do a physical exam so many times a year. And then the specialties that maybe just are a little more complex, especially with, you know, chronic diseases like diabetes or chronic kidney disease, like those patients can get really sick, and the doctors do just want to have them come in. And again, the patients do want to be seen, you know, periodically. So we do try to find that balance of, okay, let's offer telehealth like 3 times for this patient, but after the 3rd time, they'll need to come in. And it's really, again, like I said before, like we really just try to meet the patient's needs. So if patients really prefer telehealth, then we'll do it as much as we can. If they don't want to at all, oh, by all means, we never force telehealth on a patient. So yeah, we tend to see the elderly and those with more chronic conditions not really being as prone to use it. Yeah.
Thank you.
Mm-hmm.
Okay. And this actually is our last question, because some of these other questions you have already answered. And this is for all of you. How do you see the use of telehealth in your practice and profession evolving in the future?
Well, I imagine that I will continue to do some telehealth sessions because, like I mentioned previously, some people may not have transportation and the convenience, but I can see that more and more people wanting to come in, but you will become more like a hybrid program. You know, some people want to come in, and some people would stay with telehealth, or sometimes they would just say, okay, I'll come in today, but I'm not going to be able to go in the next couple of weeks, so we could switch over to telehealth. So we do have that flexibility, but I could see that, at least for my practice, it would be more like hybrid. And I know a lot of the therapists nowadays that's what they do as well. Some therapists actually have just kind of do away with their office and just do it in their home office. So meaning they just do telehealth only. So that seems to be the trend. I don't think telehealth is going to go away for that reason.
Thank you.
Yeah, I still see it, at least for now, excuse me, just as a practice extender for, like I said multiple times already, part of the problem is, you know, 50 years from now, you guys are going to be 70, but right now, the 70-year-olds and the 80-year-olds and the 90-year-olds really struggle with this platform. You know, they really, you spend 15 minutes just trying to get them to turn the microphone on. And, you know, so it's something that for now we just use, and who knows, 50 years from now we might be doing holographic stuff, you know, who knows what kind of technology we're going to have. It's probably not just going to be audio video, but with this, the way it is now, where it's just an audio visual platform, I still see it in a practice like mine, where I need to do pretty thorough neuromusculoskeletal exam. It's really going to be something that is going to be an extender, something we can use when people can't make it in for whatever reason. The visits are a lot more fun in person, you know, and I need to build trust with my patients. I need them to trust me, because I'm going to be doing weird stuff to them, sticking needles, you know, deep into their body and doing surgeries and stuff. So building that trust is important. I found that very difficult to do over Zoom. I noticed a big drop off in sort of, and the fun factor, you know, just being in the office, and they like the staff, and we have a good time during the visits. I like to have fun with the patients, and that's just harder to do. So I don't see how this will ever become something where I would want to, or even be able to just use it permanently in my practice and not see people in person anymore. It's always going to be something that, oh, guess what? You're sick today. You need your medication. We can just call you up and do it that way. But next month I want to see you in person.
Thank you.
Yeah, I think, well, for one thing, I agree. I don't think it's going away. I think it's very situational, where it's appropriate and where it's not. I know for us, we're actually using the ability to do telehealth as almost a like an added benefit for new clinicians coming out of med school, saying, hey, if you come work for us, you know, you can work from home on Tuesday and do all telehealth visits on Tuesday. And that's like huge. People love that. It's like one less day they have to go in the office. So it's almost being used kind of as a benefit in a sense on the clinician side. But in terms of the future of telehealth, I think what I would like to see is more integration with remote patient monitoring. So now we have, you know, the ability for, you know, patients to have blood pressure cuffs at home, or they can test their glucose and, you know, have that go back to the doctor's office, or, you know, like if a patient has congestive heart failure and they need to monitor their weight, they can weigh themselves at home. The information from the scale goes to their medical, or goes, you know, to a system where the doctors can monitor it. So I think it'd be neat if that could be incorporated with telehealth, so the provider could see real time as they're doing the visit with the patient. Hey, step on the scale and let me see what it is, or let's take your blood pressure right now. Obviously they can't do that if they're not in the room with the patient. So somehow finding a way to integrate those capabilities. I mean, they exist today, so I imagine it's just a matter of time. But just, you know, getting more information to the clinician and the provider so they can, you know, have as much information at their fingertips to make the right decision for the patient. I think will be neat to see, and then be able to share stuff back with the patient. We do have that today, where the provider can actually share their screen in the video visit. So like maybe if the patient's lab results came back and the provider wants to show them, like, look, a month ago you were here, now it's here, we got to watch this. They could like share their screen in the medical record and have the patient see that. So I kind of foresee that expanding too, where you know, provider could share more information with the patient, and you know, it's like if you were in person, you'd be doing it like this, but you know, with telehealth, they can kind of do it remotely. So keeping the patient informed as well, I think is something we could do better on.
Great, thank you. Thank you so much. We want to open it up for any questions. Yes.
Hi. My question is, if somebody is in, let's just say a clinician is in private practice, for instance, a certified diabetes educator, or dietitian, how do you recommend that they transition their practice into telemedicine? So how do you go from that to this?
Yeah.
Let's say you want to do the majority of your practice in telemedicine. Where do you start?
Yeah, I mean, I can start. I mean, of course, you have to start with a telehealth platform. So figure out which, you know, HIPAA compliant platform you would want to use. I know for our company, we're so big, we are very, very extreme on privacy and compliance. So there's only one or two vendors we would work with, but there's a lot out there, you know, Doxy.me, Doximity, a bunch of them that the practitioner could use. So once you have that figured out, I think it's just a matter of, you know, talking with patients, figuring out what's your setup going to be at home, you know, what's your office going to be like some things what Dr. Cabaret said, you know, figuring out how to make that personal by where you look in the camera, And then, of course, like your patients have to be on board with it. So how do you plan to communicate kind of that transition to your patients? And think through, you know, try to anticipate maybe the concerns they might have. So why is this better? Why is this the same? Why is this not going to impact the care they're going to get? I think that's something our patients have really appreciated, is like the clinicians are on board with this. The clinicians say, hey, this is a good thing to do. This is good for you, this is good for us. And so I think, you know, hearing that from their clinician helps them buy into it as well. And then it should just roll from there.
You would need to know all the CPT codes that you use, like they might be different for telehealth, and they might reimburse differently, so I would look at a business plan in that regard as well. And, you know, regarding remote patient monitoring, that hadn't even occurred to me. You know, a lot of physical therapy is going to be going online over the next few years. There's a lot of RPM programs now that are coming up.
Yeah.
And, you know, for someone like, if it's diabetes, you could be monitoring their glucose and have a dashboard in front of you. It would really, I think, work well for someone like that. But you have to look at the business side of it too. Will it pay? You know, is it going to affect your business revenue?
One of the things I do want to add is that you do want to have a consent form signed for telehealth services, and list all the conditions that they understand how it works, such as that they need to have a privacy, you know, either like in their own room. You know, some people saw it's just talking in a car and like, oh yeah, my mom's over here. No, so they need to understand, you know, confidentiality, privacy, security. All those issues need to be addressed in the consent form. So, and then also go over that with the patient so that they understand, you know, how is it different from in-person session, because in person that, you know, we as a clinician that you have that control, because they come into your room, your office, and you close the door, you assure the privacy, but you may not have that set up if they can be anywhere. So, like you were saying, like they could be shopping and like, oh, it's okay, I can talk to you. So, so they do need to understand all the conditions in terms of how telehealth is practiced. Thank you. Yes?
Is there any additional certification or anything licensing to practice telehealth? Just as long as you're a physician or a counselor or whatever, you can just.
Yeah.
Any additional
None that I
licensing
know
or
of, but
Not
like
that I'm aware
Dr.
of.
Kwan said though, there are, the regulations are complex. So like there are the regulations around like if you're licensed in this state, what you can and can't do depending on where the patient is. So that's certainly something to be aware of. And then the regulations too keep changing. So when COVID hit and, you know, the government declared a public health emergency, we had this PHE for years and it just expired May 11th. So when the PHE expired and there was no more health emergency, they changed a lot of the telehealth rules. So things like that might have changed too, whereas during the PHE, they may have been a little bit more lax about, okay, you can see, I'm just making this up, but like maybe you could see patients in other states, but now as of like May 11th, you know, you can't do that anymore. So I think the biggest thing is just making sure you track those regulations or have someone who can counsel you on that, because that they change a lot and they're very difficult to understand if you are just a lay person and try to go read them. Yeah.
Yes?
Do the insurance companies reimburse the same way for telehealth visits as they do in-person visits, or do they see it in a completely different way?
I don't know about specialties. I mean, I know for us, they have over the PHE, but that changed as well. So like they used to reimburse for, you know, say 100 different CPT codes, and now they're starting to slowly pull some back because they do, you know, they need to limit it somewhat. And I was trying to, yeah, I think some also might be lower reimbursement, like they might still reimburse you, but it's lower. There's also a factor, this wouldn't, you know, not really applicable to what you're saying, but for the patients, they may or may not have to pay a copay too. And a lot of them think, oh, it's just a telephone visit or a video visit, why do I have to pay a copay? But if if a copay is required, we're required to charge them for it. So yeah, there's all those things to consider. A lot of the health plans are following what CMS does. So that's been kind of helpful, because if you know what, the center, what Medicare is going to pay, a lot of them are just saying, okay, we're going to follow what Medicare pays. But again, you could have, if you're contracted with 20 different commercial health plans, you got to know every single plan, what they reimburse, what codes, what their unique, requirements are. So it gets complicated.
Crazy complicated.
Mm-hmm.
I know in terms of psychotherapy, there's some companies out there, they strictly do telehealth. So if you're a therapist, you sign up with them, the reimbursement rate is very low. So it's different. So, yeah.
Any other questions?
Yeah, so in your experience and perspective, how have you seen telehealth help with like burnout, especially with COVID? What have you experienced? Have you seen, has it helped you with burnout? Has it helped any of your other colleagues with that?
At first when we started doing telehealth, I loved it. I was like, oh, I can stay home. It was great for like the first month or two. And then I really got burnt out on telehealth. It was really hard to connect. I've been saying the same things over and over, but couldn't get that same connection, especially with people that are already kind of, hyper vigilant, a little bit more, less trusting and stuff. It was really hard to build that rapport that I need in order to do my job. And going in and out of the Zoom calls, it's, if you've got 4 appointments or 6 per hour, or whatever it is you're doing, you got to come out of that last appointment, go into a new appointment, teach them how to use the Zoom or whatever you're using. It's like, it became pretty cumbersome after a while. And we, as a team, my staff tried to come up, solve the problem, come up with the best way to do it. But it was still awkward and cumbersome. And, the other thing is patients really, you were saying how about the copay and stuff, they don't really see these as office visits. Like in their mind, it's like not really, so why would I pay a copay? Why would I show up? A lot of times they would just ghost us and we'd be like, hey, you have an appointment. They're like, oh, that's not really an appointment. So, it's harder for them to understand, no, we're working, like this is our job and we have an appointment at 2 and you got to be there. Like it's not just, a little phone call or something. So that was something that we struggled with. But I got burnt out on telehealth after a while. I don't know how it is for you.
Yeah, I think in the beginning we didn't have any choice during the pandemic, so you have to just sort of like back to back seeing people each session through the camera. And I think, for almost all of you, you're so used to looking at the computer and, in lecture and talking to your friends, but, we're not used to that. So that makes it really hard. And so when I remember I actually went back to the office and did telehealth, but I had this feeling, I'm working, I'm in my office, not in my home office, that I can just wear my yoga pants and it's fine, So, and I remember like when I started having people coming in, people, feeling more comfortable coming back in, and I was excited about seeing people in person, and they were excited to see me because again, it's like Dr. Carol Bray saying, is that connection. It makes a difference because part of the psychotherapy is about human connection. So if you don't have that, something is lacking. Now, some of the things that I have been doing is that if I have a new patient coming in, they may suggest, or I may suggest, okay, you want to do telehealth because you might be an hour away. So, but why don't you come into my office for the first couple of times so you know who I am and I know who you are, and then we started having that connection, and then we switch over to telehealth. So one of the things is we do have that flexibility how we do it, but it was quite tiring for a while when you just kind of look at the camera for hour after hours.
Yeah, sometimes I'd have a Zoom meeting at the end of the day with like family or friends, and I just,
Oh,
I can't
yeah.
do another Zoom meeting, oh my God.
Yeah.
And you know, I guess I'm an old timer, but you know, I still think of that doctor-patient relationship as a sacred relationship. You know, and there's something there, there's an intimacy that needs to be there that you lose over an electronic format.
Yeah.
It's just not the same. And it, you know, it's like you lose, you don't convey as much information in both directions.
Yeah, I think as a therapist, the session is much longer,
Mhm.
so they do think that it is an appointment. So they don't, you know, they wouldn't think, oh, this is not an appointment, we're just talking. No, we're having a whole entire session, you know, 50 minutes, whatever. So, so they don't have that misunderstanding as
Mhm.
your patients might have. Yeah.
Thank you. Yes?
Do you think that it will eventually evolve to where telehealth does become? I know that you guys up here are saying we need this human connection, but we are slowly evolving to screens. What I am going to look like at 70 or 80 is different than what my grandmother looks like. So do you think that eventually, I mean, obviously surgeons, anybody who has to be there physically to do their job, but you know, the person who's like, hey, I think I have strep throat. Do you think that eventually it'll just be, we won't have these big offices and we will turn into a strictly screen?
I think it's definitely gonna flip.
Yeah.
It's probably gonna be more of that and less of in person.
Yeah, that's what I want.
You know, but there will be, yeah, instead of being, well, once in a while we do telehealth, it's gonna be more like once in a while we do in person. Yeah, and it depends on what you have and what you need. Probably it'll all be initially an electronic encounter, and then the decision will be made, hey, I need you to come in person. So it'll be to a point.
I know we already have, you know, we want everyone to go to electronic records, we want to have all of that stuff, we want to have our little portals, where we can go check our, you know, our tests and see all this, you know, I know I go get my blood work done, it's like, bing, it's right away, I have it in my hands. So I can imagine that, you know, even through Zoom and teachers, that's how we've been going to school and doing things, so it's almost like you expect for that to be happening, and sometimes when it doesn't, I'm kind of like, oh, I gotta go, I have to go in for this? So.
You know, I think some of this older generation has to wash out for that to happen too. It's hard to do today, because yeah, everybody in this room would prefer that. But most of my patients, you know, are older and really don't want that. You know, so yes, when you're 70, it'll probably be a common thing. But right now,
Yeah.
it's not quite, not everybody's 20.
Oh, I'm not 20.
Yeah, I agree with that. I think it'll be a shift over time. I think the technology is going to have to get a lot better. I think we need to do a better job with health equity, so ensuring those patients that don't have mobile phones or computers or reliable Wi-Fi, like that's an issue, and until we can level that playing field.
Those should also be the same people that don't have a vehicle to get.
Yeah, exactly.
So it's
They're the most needy for that service. Yeah, exactly. And it'll change. I mean, it's going to change everything. Like as we shift that way, think about doctors' offices. Like right now, I don't know, at Optum, you have a doctor with an office, and then he or she usually has like 3 exam rooms. But maybe in the future, when more visits are telehealth, you're not going to need that huge office space. So it's going to be flex space where like it's like hoteling, they call it, where like the doctors share the office, and then they only need, you know, 6 exam rooms for 6 doctors as opposed to 18, and you know, office spaces will start shrinking. So it's going to be interesting to see how it evolves. But I think if the technology can keep up and continue to get better, we will see that shift.
Yes?
My question is, would you benefit if corporations offered the hardware for you guys to ensure like a constant, like strong connection between you and the patient?
You mean offered the hardware to the patients?
No, to you guys.
So like a computer screen, or what do you mean?
Yeah, but like top of the line technology. Something where since technology's been evolving for so much, sometimes like having like the best technology can help ensure a stronger connection on your end, so you can actually pull from the patient on the other side of the screen.
It's probably going to go that way, you know, in the future. I don't see that happening in the next, 5 or 10 years. I think we're going to keep limping along like this. And then someone's going to invent something great, and probably, it's going to be, the medical office of the future is going to be very different, as you were saying, than it is today. And will probably involve more technology and less actual physical space.
Well, but that doesn't take away some of the challenges that we have been talking about in terms of building trust, human connection, building a relationship with another person. In psychotherapy, trust is one of the most important elements. So you do want to have the person to be able to trust you. So having this in-person session makes a big difference. So even though with the best technology, in my own personal opinion, I think that in terms of psychotherapy, that in-person session probably will stay. Now, 50 years from now, I wouldn't know, but I think that at least for the next maybe so many years, 10 years, is still important, right? Because part of that is really about people coming in regarding a lot of relationship issues. So one of the things about having a relationship is to begin a therapeutic relationship with your therapist. So being in there together, talking, having your therapist to observe how you are in terms of your body language, how you express emotions. Some of those things are still missing, even with the best technology, I think.
Thank you. Yes?
For patients that choose to use strictly telehealth and telemedicine, how do you make sure to get effective informed consent?
That's a tough one. So we dealt with this, especially when COVID first started, especially for new patients. So typically what happens, the patient will come into the office to be seen, and they fill out all the new patient paperwork, right? Like the 20,000 forms and all this stuff they have to fill out every time, and they hate. And then in one of those forms, you give consent to treat. So that's the most important, because without a consent to treat, then the clinician should not be seeing that doctor. So when COVID hit and we had new patients and they wanted their first visit to be telehealth, we had no way to get them to sign this form. And so we actually had to create a process where they could complete the forms online. And then we would, once we obtained it electronically, then we would allow that visit to happen. So that's consent to treat. I think Dr. Kwan mentioned the consent to do the telehealth visit too, which is another important piece to it. I know for us, when the doctor starts a telehealth visit, they open up a note so they can start their documentation in the EMR. And we have the ability to pre-populate. So they open a telehealth note, and we have the ability to pre-populate certain elements of that note. And like the first thing was, obtaining the consent to do a telehealth visit from the patient. So when they open the note, they're talking to the patient, they know that's the first thing they have to say. And so we're basically prompting them or feeding them, helping guide them to ensure they don't miss anything when it comes to consent. So for us, for me, in more of an administrative operational position, we always look for ways to try to make it easier for the doctors to do the right thing. And so that's how we approached it.
Yes?
I have a question about documentation, note taking. So when you're in the clinic, or you're in, taking your notes, let's just say private practice, versus a telehealth visit, do you feel that the documentation is the same, less, or greater?
It should be just the same, yeah. I mean, there's certain requirements how you document your notes, your clinical notes, so there's no difference because it's still a session, and all the important things should still go into your notes.
Yeah, I just wanted, because you're not seeing that person in person, so I wanted to know if you had to kind of really dot your T, really make sure everything is very documented because you're doing a telehealth visit. So you find it's the same?
The information's the same. In other words, when
I'm talking about your notes that you're taking as
Yeah.
a clinician, as a physician or a clinician.
I'm working in an EMR, and when we do a telehealth visit, I clearly label it as a telehealth visit. And then, for example, when I'm doing my exam, anything that I can't do because it's telehealth, I don't just take it out of the exam. I say not performed. So, to make it clear that, yeah, normally I would do that test, but I can't because it's over telehealth. So I think it is important to, document that you're aware that you're in a different type of a visit and it's affecting what you document, as opposed to just saying, well, I didn't do that test. And it's like, well, no. Or not documenting that you even thought about doing that test. You should, I think, put anything that would be in a normal in-person visit, you should at least address it in the note and say, hey, we didn't do that because it was not an in-person visit. But I don't think there's more information that needs to be there than, than if it was in person.
I'm more of a liability issue.
Yeah, so there's always that little disclaimer I see in everybody's note, this was a telehealth visit, and everybody's is a little different, but there's sort of a little disclaimer that most doctors put in their notes, whatever they think is important to put there, like, during COVID, everybody had, due to COVID-19, we're doing a telehealth visit, and now you can't really say that anymore. It's just like, we're doing a telehealth visit.
And then in terms of billing code, there's a code to indicate that it's a telehealth, so.
Any other questions? Yes.
So with these advances in technology, do you guys think more clinicians are going to be open to home health? Like, do you think there's going to be an increase in home health?
Meaning where the clinicians go to the patients' houses?
Why would technology increase? Clarify your question.
So you know how we were talking about how maybe people are going to do into hotel where clinicians use the same office space? Do you think it would move out of instead of doing big clinical practices, instead because the client feels more safe at home, they would want to perform these things at home instead of coming to the office?
So the doctor would do house calls.
Yeah, I think there's definitely a market for that, but I don't think that would be the mainstream, just because you can only see, depending on how far away the patients are, right, that there's a lot of travel time involved, and that's typically not the best way to spend, the clinician's time. But again, there's home health agencies that send nurses out and caretakers, and there are doctors that do house calls, but I think that's more of a niche and not something that we would see expanding on the day-to-day patient care.
It's a lot easier to get 30 people to show up in one place, like at a concert, than trying to get Taylor Swift to go to everybody's house and perform. I'm going to be here at this time, everybody show up. And that's kind of what it is every day in the doctor's office. It's I'm going to be here from 8 to 4. We got people showing up one after another. It's a fast-paced environment. For me to go and do that same amount of work, I guess if you paid $2,000 a visit or something, for me to drive across town, it's going to take me 3 hours to do something that would have taken me 10 minutes. So it would get very cost prohibitive too.
Any other questions?
To add on to hers, what about mobile clinics? Do you think there'll be more of those?
I think it'd be nice if there were. It's another way to reach people. It's all nowadays. It always comes down to financial, right? It's like insurance companies and payers are not really thinking about how they can spend more money. They're thinking about how they can spend less money. And so the challenge is always, okay, I've got these great ideas, and that's the challenge for this generation. How do we make that work in an environment where nobody's paying for anything? But mobile clinics are great. And I had friends in the addiction world who are like, why don't we just get a van and just drive into those neighborhoods, and open up the doors and say, here we are, for those areas where people aren't coming and looking for addiction treatment. So mobile clinics would be great. Yeah. How do you get it paid for? You mean in the world or in my practice?
No, in your practices.
I think the diagnostic acumen definitely went down. I'm not saying that they were wrongly diagnosed, but you know, when you meet a patient, you formulate a differential diagnosis in your head, right? I say, okay, your back hurts. It could be the disc, it could be the facet joints, it could be the central canal, it could be, you know, all these, could be the muscles and tendons and ligaments. And so you start to, you know, you look at MRIs, you do a physical exam, you talk to the patient, you get their history, you know, 80% of what you need to know is in that history. And then you just kind of start going, okay, I think my number one suspect is those facet joints, but it could be the disc. So you start to say, all right, let's do a facet thing first. I think that differential stays murkier for longer in a telehealth setting. You can't zero in and sort of create a hierarchy of your, you know, your thinking as quickly. So it's more like throwing darts at a board. It's not blind, but that educated guess is less educated, and it's more of a guess. And so, you know, I don't know about misdiagnosing, but definitely not as precision, less precise. I don't know. How do you feel about that for what you do?
Well, I think for me, because, you know, we do spend the same amount of time in session, and I think that it's not like a misdiagnosed, but again, it's like you're not seeing the whole picture. So, you know, like for instance, someone comes in and say, well, you know, presenting another problem, I'm just depressed, you know, well, how about anxiety? And no, I'm not anxious. But then if someone comes into the office and you're tapping your feet and you could see that your hands are sweating, yeah, definitely is an anxiety. So that part might be missing. So it may just take longer to get there, depending on how the patient is presenting the problems. It's like the challenges that we have talked about, that something is missing because you're not seeing the person in your office, you're getting to observe the body language, which they may not even be aware of, right? Yeah.
Are you aware of any courses where people that are thinking of going into this can take to become educated on how to, you know, be an expert in doing telehealth? Are there?
I'm not aware of any courses, but it doesn't mean there aren't any out there. I know LinkedIn Learning has a lot of information out there, and you know how the internet, I mean, you can find anything these days. So I think, like, if you just, you know, start asking the questions about, like, what do I need to know, I bet you might come across some, yeah. And again, find someone who can help translate the regulations, be my advice.
One more question? Okay.
With telehealth becoming more popular and possibly being like the primary like way that people see their physicians or their psychiatrists, do you guys expect there to be like less of a need for workers in the healthcare field? Because I mean, a provider could see, you know, 20 people via telehealth versus in person, it's probably half that.
That's a good question.
I think if everything went telehealth tomorrow, pure telehealth, there'd be a lot less need for the workforce that we have now. You don't need someone to room a patient. You don't need someone to carry that specimen. You don't need someone to greet them at the door. Just all those people would be eliminated. Yeah. You'd still need some staff.
Yeah.
But I think it would be less.
Yeah, I think too in a large organization like Optum, that the work probably just shifts. So like Dr. Cabaret said, you know, maybe there's fewer medical assistants that are physically in the office supporting the doctor, but maybe that means we need more people on the back end auditing charts and trying to make sure the documentation is accurate, or, you know, someone following up on the billing and making sure that they're using the right CPT codes and things like that. So, yeah, I think the kind of the need for in the workforce is probably going to shift a little bit.
Okay. Well, thank you so much for your time and sharing with us today. I have some names that were randomly generated. Yesenia,